We will be having an interactive 1 hour session where we will have live polls throughout the session. So I would suggest you all to please keep voting. The esteemed speaker for today's session is Dr. Fawad Farooq. He is an associate professor and intervention cardiologist at National Institute of Cardiovascular Diseases. He did his MBBS in 1995 from Prince Medical College. He did his FCPS in cardiology in 2005. He did his training in intervention cardiology from NICVD and joined Karachi Institute of Heart Disease as senior registrar from 2006 to 2009. He is also Joint Secretary of Pakistan Cardiac Society and is always actively involved in CMEs as speaker, moderator, and cardiology expert. He has made multiple research publications to his name, and he is author of Basics of ECG booklet. He's extending valuable CME support to medical community through social media and webinars. We're very delighted to have him with us. Welcome, Dr. Saab. How are you?
Fine. Okay, thank you firstly for providing this opportunity to interact on a very important subject, cardiovascular protection or cardio protection. Actually, why we stress on cardio protection, because that's the only disease, cardiovascular disease, and especially when we are talking about atherosclerotic cardiovascular disease. It's a preventable in a sense. If you take care of all the major risk factors, you really can bring its number down to almost 20-30% in terms of incidence, and you can delay the events as well. So it's very important to understand, even that's a very common thing we constantly repeating, because it's important. You always have to remember this fact that this disease is preventable. In a large number of patients, you can prevent atherosclerotic cardiovascular disease. And that's, we are seeing that if we are not really taking care of the risk factors and contemplating to act prior to happening of disease, that's what's happening all over the world, and especially in Pakistan. You can see number one cause of death, even globally, as well as in Pakistan. So it's taking our dears from away from us, and that's the goal of World Heart Federation of 2025, that premature mortality from cardiovascular disease, 25% reduction of premature mortality deaths can be reduced if we take care of the major modifiable risk factors. And that we all know that what are those risk factors. And these all are prevailing in our community: physical inactivity, inappropriate diet, blood pressure, obesity, lipid disorders, and smoking. So it's a constellation of all these things. And I don't know why they have kept diabetes in non-modifiable. Actually, these slides are not made by me. They are given to me for sake of presentation, which is a good thing to have. Aapka kaam aasan ho jata hai. But usually I am habitual of presenting with my own slides. But here you see the non-modifiable one, but I think that diabetes is still modifiable one. So it should be kept in the previous slide. Otherwise, family history, age, gender, but why they are important to identify. That means you have to take care of these people who are middle to old age, if they are male gender, their ethnicity is African or Asian, which we are. So they have more chances of having disease in spite of having no conventional risk factors. So that's the important. You have to look for these non-modifiable one as well. And when you really make a scoring, and these variables do have impact on the total cardiovascular risk. Even the patient, a person is having a single modifiable, but four or five non-modifiable, he's at very high risk. So he should be taking care of his modifiable risk factor very aggressively, even if it's one or two. Usually, if you don't have a non-modifiable one, but modifiable just one risk factor, you're not that much at risk of having disease. So that's important. That means if we are taking care of any variable, like if even a person is coming to you for other reasons, it's very important to identify these all major modifiable or non-modifiable risk factors, because that will give you an idea that how much risk your patient have of developing atherosclerotic cardiovascular disease. The key for atherosclerotic cardiovascular disease is the risk assessment, because as long as the disease is subclinical, you can't really identify the disease. People are roaming around with their plaques in coronaries or carotids or peripherals. If it's not rupture and it's not flow limiting, he may be having no symptoms at all. And you may be considering your patient a very healthy guy without any issues. And the next day, you develop a life-threatening MI. So you judge the existence of this atherosclerotic cardiovascular disease by means of risk assessment. That's very important to understand. It's always a subclinical disease going on in the vascular beds. So that means if your patient is at high risk, consider him or her as he's having atherosclerotic cardiovascular disease, but she or he is lucky enough that plaque haven't ruptured up till now, and he haven't this person isn't came onto the surface as a patient of atherosclerotic cardiovascular disease. And here you see when they present as a cardiovascular disease in male, you can say ischemic and cerebrovascular, the atherosclerotic disease comprises of almost like 80% of the cardiac disease is atherosclerotic one, either ischemic or cerebrovascular. And similarly in females, it's 75% of the time the cardiac diseases which they have is atherosclerotic, either ischemic or cerebrovascular. Ischemic heart disease, we all know, you judge by, and that's what I was talking, atherosclerosis is caused by atherosclerosis, but this atherosclerosis you can't reveal unless and until this atherosclerosis leads to symptoms, which are angina, MI, and ultimately leading to heart failure and sudden cardiac death. So that means all those who are having this atherosclerotic disease but still haven't have any of the event, they all can be judged by means of risk assessment. And risk assessment means all major modifiable risk factors and non-modifiable as well. Identify them all together and take care of your patient's risk factor to prevent the events from happening. MI, we all know, so common. And in our community, almost now we are seeing MIs in late 30s, like after 35 to 45 or even 50, like 35 to 50 is the peak strata we have in terms of male age for having MIs. Okay, you can imagine that's the peak age of a person. He has gone to his peak of career, and the moment he is about to you can say take off, he got an MI. And why is that? Not taking care of risk factors, having this event, heart failure, because all these early MIs, when and nowadays it's good to have a vigilant or an effective acute treatment available, especially to Karachiites and Sindh, and now even in all over Pakistan, thrombolysis and primary PCIs. And now you're getting more and more patients of heart failure because of a good survival after MI. So if someone developed at the age of 35 or 40 and in cheer or even inferior MI, and again, post MI, they're not taking care of their risk factors properly. Within 5 to 10 years, they develop overt failure, NYHA 3, 4. So it's also increasing the incidence of heart failure as well. Cerebrovascular disease, another presentation of that atherosclerotic cardiovascular disease, and the most dangerous one in a way that it leaves your patient with a disability, and this disability affects not only the patients, the whole family. In MI, after MI, we do give enough rehabilitation and make a patient really to a state or revive him to a state that he should be able to do his routine activities again with slight limitation. But after CVA, especially a deep one leading to hemiparesis or hemiplegia, so difficult to revive that particular patient. And that is again main reason, the ischemic one or atherosclerotic rupture plaque. There are other as well, hemorrhagic, again main culprit, the hypertension, but thromboembolic one as well, they again have some relation to the cardiac ailment as well. And stroke, again, a very common phenomenon, but unfortunately, we are having this at a very early ages in our community. So, and the important thing out of all these, you can see key fact regarding cardiovascular deaths, 80% preventable. And that's a hope for all of us. If we do enough counseling, workup in the community, that is primary care level, changing the lifestyles, taking care of all major risk factors, we can prevent this disease. That is very important to understand. We can't treat. So difficult. It's expensive. It needs really a lot of facilities. But prevention, it doesn't cost much. But we have to stress on appropriate prevention of the disease. And today's, we are mainly focusing on the role of ACE inhibitors in that prevention. You can see that these golden drugs have shown enough evidence. If we use them in hypertension, in heart failure, in atherosclerotic cardiovascular disease, they all, in all these situations, they have shown a phenomenal benefit. If we use them appropriately in right patient at right dosages to take care of their blood pressure targets, reducing afterload and disease, getting disease modifying effect even after MI, and their vasculoprotective benefit, that all those who are high risk of developing cardiovascular event, if you use ACE inhibitors in them, can prevent that vascular events, and not only the vascular one, you can take off their renal status as well, which is a very important comorbidity in a cardiovascular patient, which really tips these patients and increases the risk of events as well as the risk of complications after the event. Very important. And I just quickly go through the evidences available with these ACE inhibitor, and out of these ACE inhibitor, today we are focusing on Ramipril, which has shown itself to be a gold standard for sake of vascular protection. Apart from having its antihypertensive effects, the Ramipril is the only drug which has shown a phenomenal vasculoprotective benefits, apart from controlling blood pressure, apart from being used as a drug for heart failure. It's a vasculoprotective drug. And these are the events with it. ACE inhibitor, Ramipril as a cardioprotective. But prior to going into the evidences, we have a pool for you. So I'll just pose a question here for you and want you to answer that question. Yeah, Hina, can you pose that
Yes, sure.
questions for the
Sure,
audience?
sure.
Yeah.
Here we go.
Here's the question. Hope study. I'm not talking about anything. I haven't told you anything about hope. I hope that our audience will get what the hope is. So, heart outcome prevention evaluation study, that was the hope study, proved vasculoprotective effect of lisinopril, ramipril, telmisartan, valsartan. How they can answer, Hina?
Uh, they can vote through their mobile phones or computers.
Okay,
And
so I'm
so far,
giving
I've
them
received
few
13
sec.
answers.
Oh, good. I'm giving them just 5 seconds. Please quickly vote so that we can go to the next question. Isn't that the strategy? They should vote
Yes,
so
sir.
that we should have result.
Yes, we'll only wait for another 5 seconds and then I'll publish the results.
Okay. We can ask the same question after our discussions of events as well, evidence as well.
Absolutely,
So
sir.
let's
So
see
let's
where that.
end the poll. Let's end the
Yeah.
poll and see how many answers we have got correct. Okay, so I'm sharing the results, sir.
You don't have to tell the right answer. Right answer
All
we'll
right.
get at the end.
Yes,
So
yes,
here,
absolutely.
although majority have given the Ramipril as that drug used, but some lisinopril, nobody have voted for telmisartan, but few voted for valsartan as well. Let's close and come to the second question. We'll repeat that poll again as well.
Sure.
Okay.
Now the
Next question.
second question is, here's the second question.
Okay. In HOPE study, primary outcomes were MI, stroke and cardiovascular death, renal deterioration, heart failure in ACS, sudden death and heart failure. So again, you have 5 to 10 seconds to answer. And we'll re-poll it again after the discussion. So keep an eye on the discussion that you should get a right answer within the discussion so that you should be 100% right at this after the second poll. Otherwise, I am going to fail. Because it will be my failure if you aren't being able to answer correctly after the discussion.
But sir, this one looks quite tough, so maybe you can extend a little time for them to vote.
But they have to choose out of four, just one. It take hardly 5 to 10 seconds, I think. So I think we should complete because we will re-poll
All
it
right.
again.
All
At
right, sir.
least they have to remember this question so that they
Sure.
should get the answer from the presentation.
Sure. So I'm
So
sharing the results.
so
So
yes, let's move
71%.
on.
Yes.
Yeah, 71 MI, stroke, CV death, renal deterioration 6%, heart failure in ACE 12%, sudden death. Okay,
All right,
okay,
sir.
I think let's move on to our presentation and come again to this poll subsequently.
Sure.
Do I have the control of my
Yes, sir.
slides?
Yes, sir.
It's not forwarding. Yeah, now I have. Okay, FDA approved indication for ACE inhibitor. Since we are focusing on Ramipril, so out of all these ACE inhibitors, you can say, but that's a FDA approved. It's not overall recommendation in a way that's a guideline AHA or as such, but FDA is approved because of the events. Ramipril is the only drug for vasculoprotective agents. So if you're using a drug, an ACE inhibitor, not in hypertension, not in heart failure, not post MI, but just for sake of vascular protection, then the only drug which has this indication is Ramipril. Certainly, if your patient is having another associated comorbid out of these MI, LVH, heart failure, or hypertension. You do have other, like all the ACE are recommended for hypertension, but for heart failure, not all. And that's because of evidences that in heart failure, these ACE have evidence. Similarly, for sake of left ventricular dysfunction heart failure after MI, these post MI heart failure. MI, during MI, you have these two. And similarly, for vascular protection, you have only one, that is Ramipril. So that's the peculiarity about Ramipril in terms of its recommendation for sake of vascular protective agent. HOPE study to compare effect of treatment with Ramipril or placebo on the incidence of myocardial infarction, stroke, and cardiovascular deaths. So that was the primary outcome that was seen in this HOPE study, and HOPE study was related with Ramipril here. So it's tested as comparison to placebo. The study was randomized placebo control, and patients group, you can see high risk with evidence of vascular disease or diabetics with any one of the other cardiovascular major risk factors. That means they are not pure hypertensive. They were the patients who were having vascular diseases or diabetic with any one additional risk factors. Just seeing their vasculoprotective benefit with Ramipril in this group of patients. I'm just going to results quickly so that we have enough time for discussion, and that was clearly, that's a gold standard. We all remember this old study which brought ACE inhibitor into the arena of vascular protection, and especially the Ramipril one. And then you have the studies in which other drugs are tested keeping Ramipril as a gold standard for vascular protection and seen with other drugs for sake of their non-inferiority to Ramipril. So that was the benefit we get. And in every, you can say, sphere, in a way that either it's MI stroke, CV death, which was the primary outcome, CV death, all individual components, you got benefit. And others as well, revascularization, new onset diabetes. So overall and persistent benefit, Ramipril provides protection beyond the benefit of blood pressure. Then how outcome prevention 2 study to see even beyond the studied period, 2.6 years beyond it, and the curve is still keeping on separated. So it's not just a benefit of a shorter duration, it's a long-term persistent benefit which was got with in the HOPE study. And not just macrovasculature, major cardiovascular, I'm just coming to HOPE 2 conclusion beyond 5 years. Then micro heart outcome prevention evaluation studies. All those who were diabetic in this study. You can see other outcome, heart failure, worsening angina, development of diabetes in people with no history of the disorder. So you are getting enormous benefit, nephropathy. So almost taking care of everything with that ACE inhibitor there. Here you see the benefits. Nephropathy reduction, cardiovascular mortality, MI, stroke, in diabetic. So every group got benefit. So it's not just an overall endpoint, it's all individual components in which you got that benefit. So ACE inhibitor with Ramipril can consider as a preventive intervention with multiple mechanisms of benefit, including lowering of blood pressure. And Ramipril was beneficial for cardiovascular events, avert nephropathy, in people with diabetes owing to ability to decrease in blood pressure. This treatment represents a vasculoprotective and renoprotective effect for people with diabetes. Then this was an AIRE study that Ramipril was used after acute infarction Ramipril study, and again got benefit out of it. So to patient with clinical evidence of heart failure on 2nd to 9th day of MI, significant and substantial reduction in all-cause mortality. Follow-up continued 6 months. Efficacy extension study, again seeing the prolonged effect which were also there. So this was a summary of ARI-X study extended. So persistent benefits. We are coming again to our poll. So let's re-poll again. Poll question 1 again. Yes, Hina, over to you.
Yes, sir.
Let's see, do we get some improvement in the answers or not?
I am sure we will. So here we go. Question number 1.
So let's re-poll again. Heart outcome prevention evaluation study proved vasculoprotective effect of lisinopril, Ramipril, telmisartan, or valsartan. If you get more than 50% answer, I think you can show the results.
Just about to be about to reach 50%. So then I'll display, sir.
But in this, it may be possible that some may have joined afterward or at the end may got wrong again. But let's see.
All right, let's see. Here we go with the results.
Oh, improved.
Yes.
From 71 to 95%. But still,
Yes.
some of the people opted for telmisartan as well. I don't know why.
Like you said, maybe they joined afterwards.
Yeah. So let's come to the second one, I think. So we got improvement.
Yes. So here we go with the second question.
Second question.
So far, we have received 10 responses. Dear doctors, please speed up. We will be closing the poll soon. Another 5 seconds, last 5 seconds, and then we'll close the poll.
Okay.
5, 4, 3, 2, 1. So here are the answers.
Oh, again improvement.
Yes, absolutely. 94%.
So 94% of the people rightly answers both. So we improved from 70 to 90%. So absolutely. I think I have passed my exam as well.
Definitely, sir.
Okay. Do I have control right now?
Yes, you do.
Okay. It's not going forward. Yeah. So just we are coming to conclusion, and after that we are open for 5-10 minutes for question and answer. So Ramipril has the broadest FDA approval, which include reduction in risk of MI, stroke, and death from cardiovascular causes. Prescribing the full daily dose of a documented drug is important, and that's very important. If your patient have slight leverage in blood pressures, always try to keep your patient on highest possible tolerated dose. Don't just keep on those homeopathic doses of captopril or lisinopril or even ramipril. Then you'll get the maximum benefit out of these drugs. All 10 marketed ACE have been approved by US Food and Drug Administration as we have already discussed that in relation to various indication, but the vasculoprotective, we know that Ramipril has this peculiarity. Prescription of a generic drug with incomplete documentation of fully effective doses. अब मैं ख्याल है ये ज़्यादा कुछ कंपनी की बातें हैं नीचे. So I think overall, but I conclude there are no doubts that Ramipril has this peculiarity, has this exceptional quality of vascular protective. The only thing I think nowadays we are not using it so frequently because of the reason of cough, which we encounter with ACE inhibitor. But I personally still believe all those who are tolerating ACE is still better as compared to ARB as long as your patient is tolerating. They are cheaper and they have proven benefit to a vast majority of patients with different characteristics. So I think with that we end our presentation. If any questions we are seeing in chat box or
Yes, so we have got two questions actually. One from Dr. Altaf Shima. He's asking, what is the incidence of Ramipril in your experience? I think he's asking about the cough experience.
actually, it's very difficult to say as such because we at a level it's not very frequent to see a follow-up of your patient. So I think it's good to ask to a general practitioner who is seeing these patients frequently. So we hardly see a patient within 2-3 days because our usually the appointments take months. So that's why we are very choosy in writing drugs to different patients. So that's why we are very infrequently write ACE. Most of the time we are writing ARB because of only that reason that even 5-10% of the patient, if they develop cough, they are unable to come to me. But usually I don't think it's that much. But एक को भी हो जाए तो वो हमारे लिए बड़ा मुश्किल है क्योंकि वो मरीज का लेकिन प्राइमरी केयर फिजिशियन के लिए इतना बड़ा इशू नहीं है. यू कैन से इफ यू हैव एनी थिंग ऑफ सच काइंड यू कैन कम टू मी नेक्स्ट डे. तो प्राइमरी और सेकेंडरी केयर पे कफ इतना बड़ा इशू नहीं. मरीज आपको आके बता देगा कि खांसी हुई, आप उसका सब्स्टिट्यूट लिख देंगे. उसकी वजह से आप 90-95% को डिप्राइव्ड एज से ना करें. हमारी मजबूरी होती है एक मरीज का दोबारा मिलना हमारे से बड़ा मुश्किल होता है. So it's very difficult to answer this question.
Then another question we have from Dr. Javeria Ali. She's asking role of dispirin in prevention. Please elaborate.
Actually, it's not dispirin. I think aspirin nowadays, it's a very limited role in primary prevention. Secondary prevention, it's there. But in primary prevention, it's not that case which we previously used to hear कि 40 साल के बाद हर आदमी को aspirin लेनी चाहिए, but that's not the case right now. Even your patient is diabetic or hypertensive, you have to calculate a holistic risk of your patient. If you're having 3 or more than 3 major risk factors or multiple risk factors, strong family history, then you can only give aspirin as a primary prevention strategy. Otherwise, it's not indicated in single or even 2 risk factors. There is a whole system of calculating scoring. If a patient atherosclerotic cardiovascular disease score, which is done by AHA calculator, if it's more than 20%, you can give in primary prevention.
Next question is from Dr. Mohammad Ajmal Bhatti. He's asking which ARB is recommended for heart failure.
I think ARBs are all ARBs which have evidences. It's valsartan and candesartan. These 2 drugs have shown evidences in heart failure, and that's why these 2 are. If your patient is not tolerating ACE, you can switch to valsartan or candesartan.
Thank you, sir. Next question is from Dr. Faik Ali Abbasi. He's asking, sir, what to do if someone develops dry cough with Ramipril? Should we change it or continue with same drug and treating the symptoms only?
No, it's depend on. That is a good question in a way that you have to judge, is this dry cough is really due to drug or there is something else? So if you are sure that this is due to drug, then you have to switch. Sometimes it so happens you switch one class to another, your patient may tolerate, but sometimes you have to totally, you can say keep a patient off ACE inhibitor and have to opt ARBs in that situations.
Thank you, sir. Another question is from Dr. Kamran Khan. He is asking difference between ACE inhibitors and ARBs regarding post-MI cardiac protection, cardiac remodeling.
More evidence is with ACE. You have multiple ACE which have shown benefit. But again, there is evidence with valsartan as well, Valiant study. So as such, there are no head-to-head trial between ACE and ARB. That is no such trial in which we have used one ACE or one ARB and seen in comparison with each other that is there any benefit or not. There usually you can use. So it's, but still we recommend if they are intolerant to ACE, then switch to ARB.
And then we have a question from an anonymous attendee who wants to ask the side effects. Just the question is side effects. So if I'm not sure if
we already have discussed cough,
yes.
angioedema, hyperkalemia, that you have to look for these things in patients, especially renal compromised patient. Always keep an eye on potassium.
And there are two doctors who wants to talk to you. Dr. Jendo Khan, I've unmuted you. You can ask your question directly. He has been raising his hand since quite long. Yes, sir. Here we go.
Sir, what are the side effects we give for prolonged time? Because patient will take it for many years. For that patient, I'm asking.
Okay, actually, as such, there are no such side effect of prolonged use. These side effects can happen even with one dose, but prolonged use in a situation where you have additional comorbidities, like if your patient has heart failure, you have to keep in. Once you started this drug with hypertension, and subsequently after 5-10 years, your patient developed renal compromise status. So in that situation, you should be more cautious. Otherwise, there's no such thing. ये public में भी होता है कि ये दवाई हम 10 साल से ले रहे हैं blood pressure की, क्या अभी भी ले सकते हैं? As long as it's not causing harm, which are, even if you have taken at day one, if you have that comorbidities, you can have that situation. So just prolong लेने से कोई साइड इफेक्ट नहीं होते. जो साइड इफेक्ट हैं वो डे 1 पे भी हो सकते हैं और 10 साल के बाद भी अगर आपने वो इश्यूज आ रहे हैं तो हो सकते हैं.
Thank you, sir.
Welcome.
Thank you, Dr. Khan.